Welcome, everyone. We're going to start very, very soon. We are just waiting until more people will join. We had more than 100 registrations, which is very exciting, actually. And just in case you don't know where you are, this is the webinar on mental health and psychosocial support. This is amazing, incredible 1 hour that we have prepared for everyone. A lot of the things that we will share is related to the work that we're doing in an amazing European EU-funded project in the European Network of Youth Cancer Survivors. And I believe that that many people joining tonight are also part of this amazing network, and either volunteering or contributing or benefiting from the different activities that we're doing here. So we're just going to wait a few minutes. Here we go. Mental health and psychosocial health. And while you're joining, actually, yeah, we just actually really wanted to share with you, because we found it very interesting that we looked at the registrations, and we saw that patient advocates and young people with lived experience actually were about half of the registrants, and about a quarter of registrations came from healthcare providers, which is amazing, because that's what we really want to do, to be able to connect different stakeholders. And we also had caregivers and some other people who didn't tell much about themselves. So here's your chance. How about you scan the QR code and please tell us who you are in the audience. You will see that we have 4 categories: patients or survivors or caregivers or people representing cancer patient or cancer survivor organizations. We thought it's one category. You're somewhat affected by this experience. Yes. And we really see that most people here tonight are actually from that category. Healthcare professionals, 5%, 12%, go for it, go, go, go. Let's see us. And I'm going to be asking you, who are the 15%? Oh, sorry, yes, the 15%, the 17%. So maybe what you can do is let us know who you are, so we know what other categories to include next time. Hi, everyone. We see people joining. I recognize some names: Anna from Romania, Eric from Sweden, Raluca Grosu, I think possibly also from Romania, Magdalena from Poland, Thomas Kapak, yay, healthcare provider from Czech Republic. And then we have Asta from Lithuania, and I can't keep up with Anna Russo from Romania as well. Austria, I believe Spain. Yes, there we go. And then the Princess Maxima Center in the Netherlands. Amazing. Well, keep them coming. And let's keep the chat hot and exciting today. Any questions or notes, please leave them there. There is one thing I would like to say maybe before we start, is that tonight's conversations might be triggering for some people. If that's the case, feel free to participate as much as you'd like or as little as you want. You can be here, you can leave at any time, you can speak to others, you can reach out to peers, find other like-minded people if you would like to chat with them. And you will also find some healthcare professionals and topic specialists on this panel who might be able to answer questions later. But we just wanted to give you this fair warning that this might not be a topic that's easy for everyone. And I think, without further ado, I think we're ready to get started. So, as I said, we're promising amazing panelists today. We have a mainly female production on this webinar. It just so happens. We will hear from young people with lived experience. We will hear from clinical psychologists who are currently providing care for young people affected by cancer. We will hear from people who went into this profession when they made a career change because of their personal experience in their life. And every single person who will be speaking today has loads of experience. So before we start talking about psychosocial support and mental health, we're going to ask you again to answer some polls for us. Our question is on the slide right now on your screen. We would like to ask every single one of you participating today to tell us how important psychosocial support is in these different, we call them dimensions, but just bear with us. So we will explain. As you see on the screen, there might be some social or psychological or physical dimensions or things that might not even be related to your disease. We would like to understand how important it is to receive support in these different dimensions. So you will be asked in the next screens very specifically to rate from 1 to 10 how important is disease or treatment related implication on the social dimension, as in with regards to independent living, education, employment, financial issues. So how impacted do you feel, and how important do you feel that each and every single person diagnosed with cancer should receive support in this dimension? And remember, we will be asking you about 4 things. So this one is on the social dimensions. I don't know if we see how many people have. Oh yes, we see that 15 people answered so far. We're going to wait a little bit because we have 86 people on the webinar so far. Yeah. This is not going to be a very scientific poll, so feel free to engage and just, put out there what you really feel. We will wait until at least 10 more people contribute, so we reach 40 if we can. Keep them coming, people, please. Thank you. Okay. So this is good. Maybe we can take a screenshot for later about this. I'm going to do that actually right now, just to make sure that I remember and we can relate to this again. And we're going to go to the next one. So the next question is, how important do you consider the psychosocial support in disease or treatment related implications on the psychological dimension? So this is mental health as we know it, most of us, right? Emotional distress, chronic sorrow, fear of cancer recurrence, anxiety, I would say. Okay, I see a lot of responses coming in. In the meanwhile, I'm seeing, from some of the treatment centers, we have actually quite a few healthcare professionals joining today. This question is actually for young people with affected by cancer, but I'm not sure if we made it clear in the beginning, so it's very possible that others have answered too. In any case, I see that there's a lot of people participating, and people have an overwhelming agreement on this being a very important dimension. Okay, let's proceed to the next one then. And here in the next question, we're going to be looking at the physical. If you don't mind to proceed to the next slide. Yes. So this burden is due to physical side effects or late effects, functional limitations, fatigue, pain, endocrinological issues. It manifests for some people in growth deficiency. Some people might have mobility issues. So here we are referring to physical side effects and late effects. And having psychosocial support for these. In the meanwhile, I see more notes from Greece, from Spain, again from Romania, from Lithuania, from Latvia. Hello. Spain. Lovely. Thank you. Thank you, everyone. So again, we see that this is a very important dimension, and we see that more than 40 people have voted so far. And then let's go to the unrelated. And so these are maybe unrelated to the disease and treatment, but life happens, right? Regardless whether we are having a real tough time with our health, regards to cancer diagnosis or any other problems, life does happen. So there might be life events and family problems, and having to deal with that parallel to your cancer treatment. So if you could just, take the QR code and answer us on Slido. And we look at this. And while you do this, I would like to make an introduction for the first two presenters. And we are very lucky because we have some incredible speakers today. And the first presentation is going to be the A to Z of mental health and psychosocial needs of childhood, adolescent, and young adult cancer patients and survivors. And I think maybe it's important to make a note that I think throughout the presentations, and a lot of speakers will be referring to survivors, but it's not excluding patients. So we're really referring to everyone with lived experience and personal experience with cancer. So without any further ado, I'm going to invite Karina and Ulrike. Karina herself is a psychologist and is the managing director of CAYA Europe, the coordinator of the EU CAYA's Net European project that many of us are collaborating on. And Karina was also a former project manager in the Austrian Childhood Cancer Organization, so lots of experience with peers in her home country. And she was really focusing a lot of her personal work on long-term follow-up care of pediatric cancer patients who are now adult childhood cancer survivors. And Karina is affected by cancer herself. You were diagnosed with cancer when you were 17. You had Ewing sarcoma, and you've been a very, very active patient advocate since then. And you will be paired with no one else but Ulrike Leis. She is a clinical psychologist and coordinator of the psychosocial team of the neuro-oncology department for pediatrics at the Medical University of Vienna. And I believe, Karina and Ulrike, you are actually collaborating on many different projects, right, in Vienna. So we're really looking forward to it. Thank you so much for joining today. And please give us an overview of mental health when you're affected by cancer.
Thank you so much, Katie. Yeah, we really just want to do a really quick overview now, because we are going into like deeper insight a little bit later. But we just thought that, mental health is really a very much used term, and associations with it are very heterogeneous. And most of the time, the complexity behind mental health is usually not so clear. So this is why today in this webinar, we really don't want to just scratch the surface, but really get deeper inside. We want to start with this really brief overview of what we understand by mental health in CAYA Cancer Survivors, and what we would like to work on also in the EU CAYA's Net project and what we would like to improve. So on the next slide, you can see a model. If you can maybe move on to the next slide. This is just a model of many, many factors that may impact the mental health of CAYA cancer survivors, which are also supported by evidence. So, of course, today we won't go into detail, and I know this is very small print, but this is not our goal today. We just wanted to highlight really the complexity of mental health and the importance of a differentiated approach instead of just a quick judgment. So what you can see here, there are risk factors, of course, in this first column, and protection factors of the disease itself, and also of the treatment, of course. There are personal and social risk and protective factors. And of course, they also play a role. And as you mentioned before, also unrelated risk to disease and treatment risk factors play a role. And of course, this is what you can see under 1 and 2, and they can lead to physical side and late effects listed here. And again, they can lead to psychological and social stressors listed here in purple. But they don't have to. And equally, however, it is possible that disease-related risk factors lead directly to psychosocial stressors, for example, the fear of recurrence. So what we wanted to say is just that all these factors determine what we call the mental health state. And this is really important. What we see is that mental health really exists on a continuum. So it starts with healthy processing. And of course, it can happen, for example, if you have a lot of risk factors, but also protective factors, and you do experience late effects, but still there's so much healthy processing. So this really, all the correlations can be really complex. And there really is this dimension, what we call persistent stress reaction. This would mean reactions really adequate and normal in manifestation and degree and duration, but still, of course, it can make daily life difficult, but we wouldn't talk about disorders. And of course, at the other end of the continuum, you can find what we call mental disorder. But it's really important for us to have this whole continuum, and we're not only talking about mental disorder. And really, it's the most important thing is to have in mind all those factors and to have this differentiated approach, and that leads to a hopefully biopsychosocial treatment plan. So if you can proceed to the next slide, please. We are really happy to have such nice guidelines for all this by the International Guideline Harmonization Group. So this is really, you will have the link to the guidelines in the chat. It's really worth having a closer look and reading all the materials provided here. But they tell us that CAYA cancer survivors are more likely to experience clinically relevant impairments in mental health as compared to controls or instrument norms. And as a recommendation, the recommendation would be that surveillance for mental health problems really is recommended for all survivors at every follow-up visit at all ages throughout the lifespan. So this is really summarized what the recommendation is about. But yeah, as you can see, it is really a strong recommendation. And I think we are all really happy about this. But there is a but. It's not only about clinically relevant impairments, what you can read here, what it is called in the guideline. So if you can move on to the next slide, please. Yeah, actually, the World Health Organization really supports our approach to mental health, how we also see it in the project, because, and this you can see on the next slide, it's really not only about mental disorders. It exists on a continuum. And this, what you can see here, is really what the World Health Organization, how the World Health Organization defines mental health. You can read there that mental health is a basic human right. You can read there that mental health should enable people to cope with all the stresses of life, realize their abilities, learn well, work well, and contribute to their community, and that it is an integral component of health. And yeah, now I would like to just give the word to Karina, because there we have so many of our goals, how we see it in the EU CAYA's Net project, and what we also want to do today. Thank you.
Thank you very, very much, Uli, for this overview. And I think, Asta, you can move to the next slide, please. Thank you. And in fact, so I just also saw that, Katie, you wrote in the chat that these are very, very important points for patient advocacy. And yes, absolutely, they are. And this also comes to what we have, what our vision was for the mental health and psychosocial care part when we were planning this project. So how can we produce materials, guidelines, and so on, toolkits that can also support us in doing patient advocacy, so we can increase and ease access for young people affected by cancer to mental health support. And so when we were planning for the project and thinking about what is it that we want to achieve with EU CAYA's Net for mental health and psychosocial care, we were thinking about exactly these issues that so many of us experience in our daily lives. Yeah, actually, we're doing good overall, but still we are not perfectly well at, some days, sometimes many days, sometimes most days, sometimes no day. But it is coming up, and then we experience a lot, reactions from the outside. Oh yeah, but hey, you survived, aren't you happy? And doesn't this, weigh out or balance out certain things that you might be experiencing, like late effects, etc. And yes, sure, it does. But that doesn't mean that it is not affecting our overall well-being. And that doesn't mean that we cannot not be at times also depressed, anxious, feel isolated, or whichever on the big variety of emotions that can happen are there and experienced. So we wanted to see how can we also account for that. So to make our peers feel it is okay that you are sometimes not feeling okay. So what can we do in terms of awareness material for that? And then also, how can we find out how actually is access to psychosocial support in Europe, so that we then can look at what do we need to improve for access. So we want to look into what is healthy coping or processing of emotions, when our strategy is not so healthy anymore. Then also what are normal emotional reactions that still need to be attended and taken care of and supported. And also, how can our environment deal with it? Our friends, our families, our teachers, whatever educational or professional environment we live in. So how can we also educate our environment of these processes? And how can we give them, so these processes, more space than they have? And then also see what are, for us as community, essential but also accessible support options for this whole continuum, from things that need to be looked into, can maybe easily be helped with, but then also that the clinically relevant conditions that you can have. So you can go to the next slide, Asta, please. And so this is why here, for instance, so we just launched a survey on long-term survivorship care. And soon to come, there will be also the second part of this survey on mental health and psychosocial care to look into what is accessible, what do we need in future, and how can we advocate for it. And you will find also now the link to the survey on long-term survivorship care in the chat. So please feel free, so survivors and also healthcare professionals, to take the survey and fill it in, because our outcomes and the quality of the materials that we will develop in the project depend on your replies and your participation and your experience. And we hope that we can make things better in the field of mental health and psychosocial care and survivorship care in the future.
Yeah, thank you so much for that. So for those people who might be following us on the Facebook live stream or have joined because you've seen the webinar advertised, we have been referring to the EU CAYA's Med project a few times. This is an EU co-funded EU for Health project. Its long and beautiful name is the European Network of Youth Cancer Survivors, but it's a network of young people with lived experience, patients and cancer survivors themselves. Some came through the pediatric track, some have been diagnosed in adulthood, their carers, family members, and also healthcare professionals, policymakers, and other stakeholders. So it's a really beautiful, large project, and we hope to be able to advocate for better care. So the overview that we have heard from Ulrike and Karina, which was amazing and really, really good, by the way, gave us sort of like a snapshot of a clinical view. We've seen that there are guidelines out there, which is, again, really powerful for patient advocates to use in their advocacy. And as Karina explained, we are also trying to provide opportunities to learn from each other in this network. And the first step for that is acknowledging some of these challenges. And I think this is a great way to go straight into introducing our next speaker. Hannah is going to be speaking to us. Hannah has a master's in psychology, but she is also a acute lymphoblastic leukemia survivor, and she had ALL at the age of 14. She's also from Austria. She was very involved in the Austrian patient organization, patient group. And in fact, she is the co-founder and chair of the first independent survivors organization in Austria. But this is not your first rodeo. You have also been a project manager in this group before, and you are also a project manager currently in CCI Europe. So you will be able to speak to us from your lived experience, Hannah, but also as a professional, as a mental health professional. So we're really looking forward to it. And as we've promised, we are going to be coming to everyone in this webinar with some really, really practical suggestions and debates and discussions. Keep the conversation going. If you have any questions, you will see the Q&A button on the bottom of Zoom. So please plunk any questions there. Other than that, just share your thoughts and ideas in the chat. Over to you, Hannah.
Thank you, Katie, for your super nice introduction. I'm happy to be here today, and I suggest to start right into it. So please, to the next slide. Thank you very much. So during my research for this session today, I came across a very interesting theory that I'd like to share with you to get started to the whole topic. The Italian cognitive researcher and Italian-speaking people, please be kind, Maria Mizzelli, has pondered whether anxiety might be a combination of hope and fear. According to her, an anxious state of mind includes both the belief that the outcome could be negative and the opposite belief, though usually weaker, in a positive outcome. The mixture of hope and fear and the conflict between the two is considered to be typical for anxiety. The difference between fear and anxiety lies in their different objects. While the object of fear is a possible or even certain danger, the object of anxiety is an event associated with a possible and uncertain danger. The feeling of anxiety stems from this alternation between fear and hope. So a basic component of anxiety is the cognitive goal of knowing whether the danger will occur or not, so that the uncertainty will end. Once this goal is achieved, even if it's through negative certainty, anxiety should decrease accordingly. I thought that was a really interesting approach, and it was the perfect introduction for today's topic, in my opinion. But I would suggest that we start with the basics and look at the terms that were already used in the title for this session today. So we're talking today about a balance between fear and hope. Next slide, please. So let's take a closer look. What exactly is fear and why do we maybe need it? Fear is necessary, although usually experienced as unpleasant, part of our lives. So fear, however, is a force that drives us to cope with real threats. Occurring to a moderate degree, it increases our performance and alertness and can also lead to personality maturation. Fear and anxiety, therefore, have the right to exist. Even though today we may not necessarily have to run away from a saber-toothed tiger, this performance-enhancing effect of fear has still its purpose. It's a protective function. In our evolution, fear thus has an important place, which sharpens our senses and activates our survival mechanisms. Next slide, please. Thank you. So what is hope now? Hope is defined as a confident inner orientation or positive expectation that something desirable will occur in the future without having certainty about it. In psychology, hope is associated with a kind of primal confidence. It's present from birth, and it can be influenced by experience and the environment. So hope is also a mostly multidimensional and highly individual feeling, which arises through a process and is subject to continuous adaptation. This process can be accompanied by fear, as already mentioned, and worry that what is desired will not occur. I think the following distinction is important here. Hope is not optimism. It's not the conviction that something will turn out well, but the certainty that something has meaning without regard to how it turns out. I want to come up with a personal comment on this because during my illness and also shortly afterwards, there was never any possibility for me that I would not survive my illness and the therapy. I cannot say why, but it was simply out of the question for me. So I was always optimistic that I would survive this time. I grew older, I continued to identify with being an optimist and almost hiding behind it. I forced myself to see everything positively, to always wait for a good end, to always remain optimistic. Also, because I sort of had the feeling that my environment would expect that from me. I had always remained optimistic during a very difficult time in my life, so why not now? At some point, I realized that life doesn't work like that. Not everything always can be good and beautiful. Not everything always has a good outcome, neither for me, not for others. But I learned for me that everything has a meaning, even if it's only to learn from the events and the experiences. I learned here to hope again. Next slide, please. Thank you. So, numerous studies indicate that positive thinking and hope are good for you, not only in everyday life, but also in connection with cancer and the life after that. A positive attitude is generally associated with greater satisfaction and a longer life expectancy overall. I'm sure everybody of you knows kind of things like that, but there are also situations in which a positive attitude can actually do more than good. For example, when it suppresses negative emotions. The fact that pushing bad feelings aside is not a good tactic for regulating one's emotion was already discovered in 2006 by the American researcher Laura Campbell Sills. So suppressing negative emotion doesn't mean you'll necessarily feel them less, the scientists conclude. Rather, a further research revealed they may only become more stressful. Next slide, please. Thank you. I just put this statement on here because it was so triggering for me reading that I thought like, okay, this is totally enough for this part here. Because often the pressure to look at things positively comes not from within, but from the outside. I'm sure everybody of us knows that. Often it comes from social networks or a conversation with friends, for example. On the one hand, this is because also the general population has come to believe that positive thinking helps. And on the other hand, it is of course much easier for those around us to deal with positive emotions and simply rejoice than to deal with negative emotion. It is also often the case that as a non-affected person, you simply have the feeling that you can actively do something and thus have helped the sad, angry, frightened person. But to be signaled again and again that displeasure and anger have no place reinforces negative feelings rather than making them disappear. Traumatic experiences in particular should definitely have a place and be dealt with. To have no place for it to leads to not feeling understood. Every one of us knows this, reinforced by phrases like, just be glad you're okay now. You get the feeling of being ungrateful if you're not in a good or positive mood. But remember always, it's normal and human to be at the ground sometimes. Next slide, please. Thank you. But our cancer story, the treatment, the pain, the being excluded, the changed body image, the friends we lost, all this is a part of us and therefore cannot be repressed or positively thought away. Negative feelings are part of it and are okay, even necessary in order to adequately process what we have experienced. Boundless optimism is therefore very dangerous because it puts the other person, so us, under an insane pressure to have to be grateful instead of simply being allowed to be angry, sad, or afraid once in a while and creates feelings of guilt. In addition, this takes away some of the right to be sad or scared, which are very natural and important reactions. Various researchers show that, on the contrary, it is even more important to allow negative feelings. For example, one research group showed in 4 different studies that people who believe that others expect them not to experience negative emotions, like sadness, for example, they experienced even more negative emotions and felt less well. Next slide, please. Thank you. In psychology, there is the concept of double awareness. Very roughly broken down, this means that on the one hand, it is possible to be aware of the harsh reality of life, such as serious illnesses, limitations, chronic pain, loss, fear, death. And on the other hand, still actively participate in life, feel hope, joy, and meaning. A certain ambivalence between courage to live, despair, hope, panic, confidence, and resignation often change within a very short time. And let me tell you, this is completely normal. Next slide, please. I think I'm going to come to an end here, and I think for the end, the following can be said. Right is what feels right for you. In fact, satisfaction and well-being are most likely to be associated with experiencing emotions that subjectively feel right, regardless whether they are good or not. Next slide, please. And this is also my take-home message for you, that every emotion has its justification and function and is allowed to be felt and expressed. Thank you.
Thank you so much, Hannah. I think there is just like so much in what you have shared. We've heard some things, some more, you know, clinical and scientific thoughts, and based on research, which actually, you know, as you said, that this is a very clear theory. What I would call is like the fingers crossed theory. Like there's hope and there's, isn't it? Like,
yes,
I mean, I literally just refer to this. It's like the fingers crossed theory, because it's both very, very justified, right? And we can really recognize how anxiety,
it's justified and is necessary. That is what I really think. It's necessary to get over and continue, because
and so you need to have both present. You need to have fear present as well, because, you know, hope is nothing without that. And we usually have this quote about courage, like courage is nothing in the absence of fear. Like courage is only courage if it's, you know, if it's relating to some sort of fear.
exactly.
But I think we don't want to talk about courage. We're really talking about hope. So it's like really the fingers crossed syndrome. But you also talked about some very real things, like we need to give ourselves permission sometimes. And if you are a very positive person, sometimes you need to allow yourself to mourn, to grieve. And we will be talking also about toxic positivity later on. So stay tuned. Don't leave our webinar. Nobody has. We're still more than 80 people. So that's really good. Yay. Fingers crossed right here. Because, you know, these topics will keep coming up and we will be speaking about it more. And in the meanwhile, I know that there's also a link here that was shared by Hannah. There's the link. Want to learn more about the happiness trap? Hannah suggests reading this. It was posted by Hannah not long ago. And really appreciate also the comment from Eric. You said sometimes some people, you know, tell you to brighten up, or, oh, you know, you're here, this is good, right? It must be positive. And Eric pointed out, sometimes this helps the person who says it, because they are in distress. They don't know how to relate to you, how to talk to you. So actually they are not necessarily helping you. They might be helping themselves. But again, we will be addressing this later on. So any specific questions that anyone might have for Hannah? Yes. So, Hannah, are you ready for the question? What could a caregiver do in a situation when a cancer survivor probably needs but keeps declining help? I suppose this is referring to professional help, due to, among other things, social misunderstandings or stigma towards mental health and mental illness, or being convinced that they can cope themselves. Hannah, any thoughts? Or if Karina might have some thoughts as well. You've both been, you know, speaking about your own experience as well.
Yeah.
Yeah, I think, I mean, it's really a hard topic, and I say this in the full knowledge that I have been one of this person myself one time, and I think the thing is, the person needs to ask for help. Otherwise, when they're not aware of that they need help, or that they even want help, then it does not help to deliver some I don't know, things that could help, because they won't take it. So I think the most important point is to show that you are there whenever they need something, to stick with the person, even though when they push you away, maybe also, but to show that you're there, that you in the behind waiting to be helpful. I think that's the most important point to do. It's not about delivering tips and tricks and whatever that can be done, because this is super annoying. The person needs to come to the point where he or she says, I need help now, and I can't do it alone, and to know then that somebody is there waiting to be helpful is always a good thing for me.
It's amazing, Hannah. Yeah, so you're saying that it's very important to establish that rapport and that there should be that trust.
Yeah, exactly.
That a very, very, very good foundation for trust, so that when the person comes to that point that they might want to consider the idea of asking for professional help, they know that they will not be ridiculed. They will not be told, well, I told you so, finally, now you listen. So there should be a lot of love and support and trust, so they feel like it's a safe space for them to ask.
Exactly.
Yeah. And I think so. I totally agree with you, Hannah. And I think what's also important to know is that sometimes, you know, if the survivor or the patient, so the young person who is affected by cancer, doesn't want it at the moment, and or doesn't see it at the moment, this can also be a way to protect themselves in this moment, because maybe it would be too hard at this moment in time to, you know, confront themselves with these things, with these emotions. So I think this is also why we should not push people to talk about things or to seek help, because maybe this is their way of at this moment in time protecting themselves and doing what's right for them at the moment, and trusting that probably at some point the time will come where they will seek help and where they will see it and acknowledge.
Very well said. And I think kind of it circles back to what Ulrike said in the beginning, that that mental health is a continuum. Like, we occupy different places on this spectrum of, you know, what one might call healthy coping or unhealthy, or, you know, acute and in need of help, or, you know, managing and coping in a very healthy way. But it's a continuum, is a very wide spectrum, and, you know, the healthiest person can be at the other end of the spectrum at any time. And we just really need to accept that different people have a different way of navigating through this. But so we need to advocate for appropriate support being available. We need to teach and spread awareness so people know how to provide better support. Probably we also need to support carers and spouses and families, and how to be there for people who need them. And I think what we are doing today is we're acknowledging these different states. And as you said, you were acknowledging that sometimes you're, you know, positive, or you have more hope. A lot of people have had to do the hopefulness scale when they were in hospital. Maybe a psychologist came and asked you to fill it in, or you done it yourself. And maybe you were asked to fill out the depression scale. And this is a good introduction actually to our next speaker, because we will be talking more about grief and depression, right? Like, what's the difference between grief and depression? When is it when we need help maybe, or more professional intervention? And when is it where we just need to acknowledge that we're going through this process? So I would like to say thank you, massive thank you to our panelists and our speakers so far. Don't go far, because you will be called back again for questions. And introduce the next speaker. Her name is Alid van der Ja from the Netherlands. Alid is a medical psychologist at the Late Effects Clinic of the Prinses Maxima Center in Utrecht in the Netherlands. And I believe we have had peer visits to the Princess Maxima Center, and our young people and our researchers actually had the opportunity to visit the Late Effects Clinic to see how you deliver care. So we would really love to hear about your work, and very specifically about this balancing act and how you see it as a professional. Alid, over to you.
Thank you for the introduction, and it's great to be here. I feel very honored. So hello everybody. Yes, I will talk about the issue of grief and depression and how to make the distinction, and also about the question, is it important to make a distinction? So this will be my topics that I will cover in the next 15 minutes. Please, the next slide.
We apologize, the slides move.
Okay.
So
No,
the
that's
slides
okay.
move a little bit slowly, so we might
Yeah.
need to advance them earlier just to give it time. Thank you.
Yes. So if we look at the words in the English language, we see that there's a difference in the meaning of the words grief and depression. Depression comes from the Latin word deprimere, which is pressing down or pushing down. And if you see it in the American Sign Language, it also has the sign of pushing somebody down. And at the same time, if you look at the word grief, that comes from gravis, which we also know from gravity, and it's heavy and weighty. And in the sign language, I found it very interesting. It's a sign that is does this, but then very close to the heart, so it's heartbroken. So the question, what is the difference between grief and depression, and how can a caregiver or a survivor make the difference? It's a very difficult question. So as you can see on the next slide, there are certain commonalities that you see in the middle. So both grief and depression have sadness, a loss of interest in activities, feeling tired. The appetite can be increased, or more often it's decreased, and also sleep sometimes increases, but also some people have a difficult time with sleeping. But there are also differences. In depression, the distress is related to a more generalized lowered mood, and at the same time with grief, we see that the distress is related to the loss of something or of a person. In depression, there are more thoughts of self-harm and also sometimes thoughts of suicide. And in grief, there can be a longing for the lost person or being with that person. So that can also make that somebody is also longing for death, but it's not a longing that is related to being dead, but more being with that person. Then there's another difference that I find really important in my consultations. With depression, there is very often a very stable, lowered mood, and in grief, it comes with waves. So the waves can be sometimes predicted when the person knows that a situation is being very painful, and sometimes it can be there very unexpectedly. So, you know, these are the main differences. At the same time, you can also see that there's quite an overlap. So it's difficult for both the survivor, but also for the psychologists to really know what is going on. And in the next slide, you will see that sometimes grief will turn into depression. Sometimes if grief is really there for a very long time, you can see that we speak of a prolonged grief disorder, which is also a category in the DSM manual, which is, well, they sometimes say the Bible for psychologists and psychiatrists. But you can also go from grief to depression. So it's always difficult to really know the difference. And the most important question for me is always, does this person need professional help, yes or no? And even with grief, people can need help because you want to avoid that the process of grief will turn into depression. Important to say, grief is always a normal reaction to an abnormal situation, and depression is considered a disorder. So also, if we look at medication, I think hardly ever medication will be used in a grief process, maybe only some medication to improve sleep. but in depression, medication can be an option to consider. Next slide, please. During my consultations in our outpatient clinic, I often get the question, why did I deal with my cancer experience when I was young, when I was a child or a young adult, and why am I suddenly struggling with it? You know, this from a scientific perspective, it's difficult to explain, but more from a practical view, becoming older also means that your brain is maturing, which means that also your emotions, your social life, and your thoughts reach adult life. So I think, I don't know if you can see the whole slide, but it says sometimes in order to move forward, you have to look back, which you can see in a rear view mirror of a car. You know, sometimes if you want to go a little bit faster and pass another car, you need to look back if it's safe and if you can still do that, and then you can move forward. So that's also with the experience of childhood cancer or young adult cancer. Sometimes it's good to look back, and then it's easier to move on with life. So common themes that I have heard in the past few years that I am working in the Princess Maxima Center are displayed on this slide. It's going a little bit fast right now, so I will go over it one by one and start on the left-hand side. It's you know, I hear young people say, I feel sad about the loss of good health. I feel guilty towards my family for being such a burden. This is a topic that I address a lot during my consultations. Some people might feel guilty towards the parents for taking away time that the parents should have given to their siblings and was taken away from the siblings. Sometimes people say, I miss or I feel guilty towards those who did not survive. It's really striking that almost every survivor knows somebody that was treated in the same period that didn't survive, and they feel guilty. Why did I survive, and why didn't the other person? I didn't deserve it more than that person. I often get the question, I will never know what kind of person I would have been without childhood cancer. My previous job was working with adult patients who were diagnosed with cancer, and I hardly ever got this question because they had the comparison, had the possibility to compare between before and after the diagnosis. But when cancer happens during childhood, children struggle with this question more. People also tell me cancer took away my innocence. I was only 12, and suddenly I was thinking about you know, the possibility that my life would end. I was suddenly aware that my parents could also become ill. I was suddenly asking myself the question, will I ever marry or have children? And then on the right-hand side, you see cancer took away my normalcy. People also tell me they missed certain things in life. For instance, in the Netherlands, it's very common at the end of elementary school to have a musical performance, and the fact that you were not able to join the class, you know, doing the practices and performing, you will never have another opportunity to do this, and people feel sad about it. And then final thing that you see on this slide on the bottom, it says, I wish I would feel as confident about my future as my peers. So I hear people struggling with, you know, my peers who have the same age, they talk about their future, and I sometimes wonder how much will I have a future? Will I have children or a married life, or will I be able to find a job? So as I said before, sometimes you know, it's good to make the distinction between grief and depression, but in the end, it comes down to are you able to manage what your feelings by yourself, or do you need professional therapy? And it has been mentioned by the previous speakers as well, that it's on a scale. You know, you cannot say if this is the problem, you need help. If this is the problem, you don't need help. It's it's on a scale. So what can you do when there is not enough reason to find professional therapy? Well, it has just been mentioned already in the chat. Storytelling is a very helpful way to rethink, to think over what happens during your cancer period. So storytelling can be done by writing down your story. It can be done by looking at pictures that might have been taken during that period. Sometimes a parent wrote a journal about the medical experiences, and some people also try to do a request for their medical records in order to put their story together. There's one thing I would really like to warn you for, which is if you read the journal that was written by one of your parents, it's very important to be aware that it's not the way that you experienced it, it's the way that they as a parent experienced it. So really important to take into account, do I want to know their perspective? Because that also might increase your feelings of grief. Another way of dealing with it is having conversations with your friends. Oh, that's going a little bit too fast. Please, previous slide. Thank you. Support groups can also be a very helpful way to deal with feelings of grief or depression. Bibliotherapy is a very nice word to say that reading books about other people who experience cancer can also be helpful, because sometimes you will recognize certain aspects, and sometimes you will think, I didn't have this, so maybe I'm a little bit more lucky than I realized, or it can also be the other way around. We also have expressive arts that are a helpful way for certain people. So, you know, painting, making drawings, but also music can be a helpful way to express your emotions. And I think something we easily forget, but also physical activity and sports can be a helpful way. And I think that also addresses to the question that was raised earlier. If a person is refusing to have a conversation with a psychologist, you know, it's always important to ask what other things does somebody do. Maybe, you know, if that person is not really very eager to talk, but, you know, sports is really a way of expressing himself, that also can be helpful. So the next slide, please. So in professional therapy, we have several ways of helping people, and what way you choose depends on the issues that the survivor is dealing with, but it also depends on the qualifications of the therapist. So not all therapists are qualified in all the things that are mentioned here. So it's really important to know, you know, what fits with the therapist and what fits with the survivor. I cannot go into detail, you know, in all the things that are mentioned here. But for instance, the book that was just mentioned by Hannah comes from the acceptance and commitment therapy. So that is a very helpful therapy for survivors, because it acknowledges the pain that is still there in your life. And at the same time, it also helps you to choose the things that have priority in your life, and not to feel guilty about things that you cannot do because they are not a priority for you. So what might be reasons to seek help? Well, I think you really should seek professional help if the next situations are applicable to you or to somebody that you love. If you feel stuck in your process of dealing with your cancer history, and you have felt stuck for a long time, it might be time to seek some more professional help. If you perceive a big gap between how you think about what you dealt with, so the things that you think, I need to be thankful because I survived, I have no reason to feel depressed, but on the inside, that's not the emotions. So the emotions and the thoughts don't follow each other. Sometimes people feel a pressure, and that was also already discussed earlier, feeling a pressure to appear happy because you need to show the world that you are thankful that you survived, but on the inside you feel sad and you feel empty. And I've noticed this quite often in my consultations, that people really experience a gap between how they should feel and how they do feel. I often ask the question, do you sometimes have the thought, when I wouldn't mind not to wake up the next morning? And I find it quite striking how often a survivor is answering yes to this question. So if you are struggling with this, you know, I would really advise you to find a therapist to help you with this. That's also the case if you have been struggling with sleep problems for a long time. If you feel extremely tired and you don't know the reason. And also if you feel like, if I start talking about my experiences or about what thoughts I have, you know, I will start crying and I will never stop. So, you know, you probably know that the Netherlands is a country with a lot of water, and we like to use expressions that are related to water. So if you build a dam, which is a wall, keeps the water inside, you might be very afraid to start crying, because then it feels like you can never stop. But I've been working in the field of psychology for quite some time, and I've never met a person who was not able to stop crying. So somehow all of us have a mechanism that in the end we'll all stop crying. So don't be too afraid. I would like to finish with a final quote that comes from a Belgian psychiatrist. And some of you might also just have been in Belgium for the PenCare conference. But I think he's a very helpful person in dealing with suffering. And I recommended his writings already for some years to my patients. And recently, very sadly, he himself was diagnosed with stage 4 cancer. And he says that, and he's talking about the thought that happiness is solely your own doing, is a recipe for a cold society in which bad luck, suffering and sorrow are considered your own fault. The result is that people keep their pain hidden instead of talking about it. Sorrow that doesn't come out festers, and festers means it starts to rotten. It can make you sick. Only when we express it, it will become bearable. That's why the art of life is accepting that difficulties and shortcomings are part of life and sharing them with others. And I hope that this webinar will help you, if you are struggling with it, to share your struggle with others. So in the next slide, I put some books. I have also The Happiness Trap in it, so that's a very nice coincidence. I highly recommend that book. There's also an online course that you can follow, and that might be helpful. And my 2 books on the right-hand side are unfortunately in Dutch. But maybe for our Dutch and Belgium people, those books might be helpful. And well, I hope someday they will be translated into other languages as well. Thank you.
Thank you so much, Alid. I think you have given us so much food for thought, and I've seen a lot of the comments in the chat. I think people are extremely thankful and appreciate the things that you have shared. Some people have commented that they have had, they've experienced grief, and sometimes they don't know how well they are doing or what that means, that chronic sorrow or grief, and when is the depression, and to look for signs and to get very practical tips from you, I think is extremely helpful. And there were some conversations and a very precious acknowledgement of Jiri's child, is a little girl and going through cancer, and parents are just wondering, you know, what might be going on in her little head. But also a very practical question from Manya from Greece. She's asking, at what age is self-help really working?
I think it's already working at a very young age. Maybe a good example is that we in the Netherlands we have I think it's called a movie. I'm looking to my colleagues, but it's a movie by a childhood cancer survivor. She made a short movie, and it contains paintings that she made during childhood. So those paintings helped her when she was ill, and now she's using them in her short movie in order to explain the process that she went through. So even at a very young age, self-help might be helpful. I think, you know, if you look at a young age, the difference is that children are very much able to change from one topic to the other. So they might start about feeling grief and what they say, and then they say, when are we going to McDonald's? And for us as adults, it's very difficult to follow, because we think, oh, they are in denial now, but they are not in denial. They have had enough, you know, talking about their grief, and now it's time to move to the next thing that's important in their lives. So, yeah.
Thank you for that. And I think because I see the participants, and there are a lot of patient advocates who are participating maybe in mentoring programs that I know that Hannah was participating in, and Karina as well. And that is volunteering and going back to the hospital and supporting current childhood cancer patients. And I see that a lot of our community actually comes from the childhood cancer patients track or population. We want to acknowledge that. So like, for example, in Romania, even the Little People Association are firm believers that every single child diagnosed with cancer needs psychosocial support. So it's a vulnerability across the board. It must be provided for every single child, whether they are 6 months old, 1 year old, 5 years old, 12 years old, 14 years old. But thank you so much for all of that, and the great recommendations, and also mentioning the acceptance and commitment therapy, which I think is very important. I know a lot of young people in Youth Cancer Europe are also avid believers in it, and have benefited from acceptance and commitment therapy. So that's really good. Thank you, Alid. I'm going to bring in our panelists. Actually, so we're going to go straight to a conversation now, and I'm going to invite back Hannah and Karina. I will also invite another young person who was diagnosed with cancer when she was 22, and actually she was one of the first small cell ovarian cancer patient in the world to receive immunotherapy. I'm talking about Oriana Souza from Portugal. And it's because she self-advocated and advocated for her own needs that she was able to participate and receive the care that she needs. And she is a mental health professional by training. She has a master's in psycho-oncology and palliative care, and she's also one of the ambassadors of this EU project. And next to Karina, Hannah, and Doriana, we would also like to welcome Willemijn Vlieger. And you are from the Netherlands, Willemijn, and you have worked as a lawyer for many, many years, and then life happened, right? Your son was treated for childhood cancer at the time, and then you really maybe switched focused on things that became very, very important to you. And you are currently the scientific coordinator of the Childhood Cancer Netherlands organization. Is that correct? And you are focusing on research and cancer research. So you're a mommy. And this is really good to bring in this because there was a lot of, chit chat going on about that. And Oriana was diagnosed at 22, Karina at 17, Hannah at 14. So there we go, a wide range of experiences. And we would really like to hear from you on what you find helpful interaction and support from healthcare professionals, from others and family. So I know, Oriana, you will give us actually a speech about your own personal experience and what people should be or should not be saying to cancer patients and cancer survivors. But besides the saying this or that, let's think about the kind of support and systems that should be in place, because we've just heard Elid's presentation and what they do in the follow-up clinic in the Netherlands. I don't know what you are advocating for in Austria. So what are some of the wishes? What are kind of the things that, I'm going to put Karina on spot right now. Like, what are the things that have been there for you or have not been there for you? What should have been different?
Thank you, Katie. So what we are looking at is really the implementation of systematic psychosocial care during the follow-up period, and speaking not only for a certain amount of time, but as Ulrike mentioned very in the beginning of this webinar, along the whole lifespan. There should be structures in place. And unfortunately, we are looking like everywhere in Europe at a lack of these structures when it comes to psychosocial care in the field of CAYA, cancer survivorship. And this is a problem because we need it. But our healthcare systems are not equipped to provide such services. So if it is there, then it's a nice to have. And putting it in a very undiplomatic way, if there is a lack of money, then this is one of the first things that will probably
go, right? Like as in personnel and having the right kind of specialist. And I know that there is also a conversation on whether there is enough preparation and training for psycho-oncology across Europe. So this is another big topic that maybe we are not able to approach right now. But can I ask something? Was there something that actually worked? Some like one specific kind of support that really helped you?
So me individually?
Yes, if you don't mind.
Yeah.
Or Hannah or Oriana.
Yeah, so me, I did have, I was lucky enough to, by chance, meet the psychologist who had been working during acute treatment and who had switched to follow-up care, who said, hey, if you ever need anything, ask for me. And so I was like, oh, I can do that. I didn't know. So I asked for it. But the thing is, I had to ask for it and I had to justify that I need the support.
So this was it during follow-up care, so not,
Yeah. But this was helpful. So once I made it over this threshold of even knowing that I could ask for this, then it was very helpful. And then, of course, as soon as I got in touch with in Austria with the Austrian Survivors Group and meeting peers who experienced similar things,
That was really helpful, right? So, Oriana, talking about peers, I know that you had a very rare mutation, and actually you were looking for peer support, and actually you found something helpful in literature, but also from other global patient groups and messenger groups, and there was like a very intense looking for answers, right? But thinking back about your mental health during this whole struggle and finding a way to live and get the appropriate medication and care. Talking about your mental health, is there something that you wish that your healthcare providers would have given to you? Or have you had a really good and splendid experience?
Like Katie, of course, I didn't have that splendid experience because, as we know, mental health is not really something that it's across Europe. So no, I didn't find that much support in healthcare professionals. It was really hard. I really found some support in online communities. It was where I started to find some peers. And of course, speaking with my parents, because venting, it's very important, and expressing ourselves. And I ended up trying to have some psychological support to some appointments, but I couldn't because the waiting list was too big, and I was asking in private system, not even in the public system. So I looked for a trained psycho-oncologist, and the waiting list were like 3 months, and I suppose like, okay, in 3 months I will be better, I will find a way to cope. So basically was always about looking for some strategies. Luckily, as I was studying psychology, I had some skills already. In this sense, I could understand from the beginning that I was facing a grieving process, that I shouldn't avoid myself to feel sad or angry or yell or whatever. So that helped me in a way, but this doesn't mean that it was easy or that I was always in my best mental health, let's say.
Thank you, Oriana. You mentioned how important it was that you were able to vent to family members. And I would like to ask Wilhelmine, how was it for you? So you as a family member, as a carer, I assume, and I'm assuming here, so you need to correct me if I'm wrong, but I assume that you felt like you need to be the strong one, you need to be there for the sick person, for the sick family member, and you needed to be that support so they could act out, express their feelings, and you could acknowledge that and allow them and permit them to feel that way. Sometimes really rotten, sometimes, going from one subject to another, seemingly in denial or whatever it was. But where did you draw strength from? Where did you receive help for your needs as a carer?
Oh, you're totally right, Katie. That's what you're doing. My son is now 24. He was 4 by then. And I'm a little bit reflecting on that time as well in this panel. You feel actually like a rock. You want to be a rock because there's only one thing you want is to support your child. So what you need for that is, you have only one question to the health professional: help me to help my child. And that continues in maybe till today, but of course he's now grown up and he's not so fancy that I'm interfering in his life, but still very much in the background. Maybe you want to do that. I started actually walking, and that maybe that's what Alit also was saying in the self-help. I walked for hours and hours, which I only could do in the evening and the night because my husband was abroad a lot and you have the children during the day. So I started walking about 10 or 11 in the evening till 1. And someone told me once, but I'm not sure that it was not only walking, but it was like walking in a certain, I don't know the English words, that I use rhythm. with him, and a lot of thought. And I think at one point I stopped with it. Later on, when we were really struggling with school, and you know, you got sometimes also frustrated because you think, is it puberty or is it due to late effects, and you want to go in quickly through school, which not happened. And then I worked again on this, and you mentioned it already, is this acceptance therapy. And that really helped me in seeing my son on the road he's on. And I felt a tremendous trust in him and respect for the road he's walking on. And that helped us a lot.
Wow.
And since then, actually, I can feel I don't feel much grief or sadness anymore. And very thankful for his life and also for this life, with everything what it brought him and us.
Thank you so much. What I'm really hearing is professional help and the need for it, and also, you know, self-help and self-awareness. Actually, I think it really starts with self-awareness, right? Just being self-aware. Yeah, and you mentioned walking. Can I ask Hannah, do you have any? Do you remember back anything, or even just today? You're in your 20s, you know, and as we said, it never really goes away, and we're kind of advocating for lifelong support for those ones diagnosed with cancer. Is there something that you do sometimes? Is that yoga, cooking, reading, walking? Is there something that you do because you know it helps you?
First, thank you for the 20s, Katie.
Take it.
Actually, it's my 30th, but I take this as a as a compliment. Thank you. Well, that's very hard to say. It changes actually. So it's kind of every day something different that helps me. But I think actually that the most that helped me the most, that were thinking and reflecting the topics I actually talked about today, because one of my biggest things that I was really struggling with, and I'm still struggling sometimes, is this force to be happy and to be thankful all the time. It's not really a force that comes from the outside. It's really a force that comes from inside of me, and being aware of that, that I do this to myself, this actually helped me the most. And there were different things on my way that led me to that point. And it was yoga, it was reading, it was also watching, you know, series on Netflix, and there was something coming up in a completely different like a topic, and I was like, wait a moment.
So not
this
a cancer,
sounds familiar to me.
Cancer character being, you know, a character.
It's not even a cancer character. Like for example, like for example, the last series I was watching was Sex Education. I don't know if you know it.
Yeah.
And also there were some topics between the protagonists, and I was like, wait a minute, this sounds or feels familiar to me. And then I started to think on it and doing a further process. So I think this sounds super stupid, and I don't know if it's helpful for anybody out there, but I think it's everyday's life and being aware of the processes that are going on in everyday's life in between the people that you meet and the things you're thinking, and yes, doing it with this in mind helped me the most, and doing what your stomach says you.
What your guts tell you. I mean, what we're hearing is a lot of good advertisement for self-awareness. So self-awareness, hip hip hooray, that's what we really, really want, right?
Yes.
Thank you for sharing all of that. I would like to invite Elliot to maybe answer on the questions in writing, if you can. There's a very specific question on depression and grief. And I would like to say a massive thank you to our panelists. You've been absolutely amazing. Thank you so much for answering these intimate questions. Don't go far. We might come back to you and ask you more about, how you cope with different things. But now it's time for us to hear from Oriana on what we want others to say. Before that, could I ask Asta to maybe pull up the poll very quickly, and we will do it really, really fast, if you don't mind. So there's a poll question on, and here it comes, everyone, so get ready. So we would like to ask people with lived experience and caregivers, if you have ever received psychosocial care. So think about it, have I not? How well did you feel that you were understood by the psychosocial professionals dealing with you? So if you did receive psychosocial intervention, any sort of care, help, therapy, or psychological consultation in the hospital or in the follow-up clinic, or privately, I guess. Ooh la la, this is the first time we see a very, very divided graph board, because with all the previous polls, it was like, yeah, very important, this and that. Okay. This is not really a good reflection on the currently trained professionals. Ulrike and Alid, you're not in the 28%. You're in the 16%, I'm sure, who have received 0.10 or A+ for the way you have helped your patients. But this is really interesting to see. So we're going to keep this in mind. And thank you so much for the people who have inputted their thoughts on this. We will keep this in mind, that there seems to be a disconnect between the needs of young people being diagnosed with cancer and the kind of support that's available out there, either in the system, either around them, either through their families, privately, therapy, whatever that is. And we're gonna go straight to Oriana. And I know that Oriana also prepared some slides. So what to say or not to say to AYA cancer survivors, so that's adolescent and young adult cancer patients and survivors, about mental health. Take it away, Oriana.
Thank you. So you can pass this slide, Asta, please. Okay, so briefly, I divided my presentation in 3 parts. I will give a quick overview about communication. I will focus in the elements of communication. Then I will speak about what to say, not to say to IS cancer patient. I will give some examples. And finally, I will give some tips and advices to improve communication. Next slide, please. Next slide, please, Asta.
I think
Okay.
there's a slight delay, so
Yeah.
to say it early on and maybe still keep talking, or go ahead.
Okay. So we all communicate, we do this automatically, but communication actually presupposes 3 elements, 3 basic elements. We have a message, we have someone who is the sender of this message, and someone who is the receiver of the message. And when we have a conversation, the sender may switch the role and become the receiver, and vice versa. And what adds complexity to communication is the way we interpret the message, because there are different elements that influence the way we decode what has been said to us. So, for example, if we are having a conversation, we should be aware that it's impossible for us to not communicate, because even silence is a way of communication. Then we have verbal elements, like the words we use, and this can be orally or written, and non-verbal elements like the gestures, the way we write or say something. And Obviously, the way we interpret is also related to the communication we have with the sender. So do I know this person is a friend of mine or is just someone else that I meet? And when we decide this type of relationship, of course, if he's a friend, maybe we feel like we are in a symmetric relationship, like we are side by side. But if we think about doctor and patient, sometimes the patient sees the doctor having more power, like is an asymmetric relationship. So both receiver and sender interpret the situation according to their own personal experiences, personality traits, and point of view. Next slide, please. So basically, who is communicating with the CAYA cancer patient? Well, I would say everybody. So directly, we can think about the healthcare professionals, friends, family, or everybody in this circle, social circles. But we can also think about indirect ways of communicating with CAYA cancer, like policymakers when they decide the support they are providing for us, journalists when they are speaking about cancer. And do they all know how to approach the sensitive topics for CAYA cancer patients? Do they all know how to support us through the different phases during treatments and even after treatments? Unfortunately, no. Next slide, please. So what we know is that this poor communication can put a toll on mental health. So please don't misunderstanding me. I'm not saying that it's just communication that affects mental health, but we know from research that impacts. So for example, if we speak to our friend and our friend is not understanding us, this may lead to our isolation or to our social anxiety or difficulties to maintain a relationship and so on. So poor communication can really affect mental health. And this can be done by everybody that I mentioned before. So even decision-making and treatment adherence, and this is not only done by a bad communication in the healthcare system. All people or every people around us can also impact in our decision making and treatment adherence. Next slide, please. So this slide just shows some examples of models to improve communication in the healthcare setting. As it's so difficult, so complex to communicate, there are some guidelines, some models that help healthcare professionals to speak in these different contexts, like disclosing bad news, terminal illness, etc. But in the end, if we look carefully, what we extract from the different models is always that healthcare professionals should communicate with empathy, active listening, respecting the patient in different ways, like religion, culture, all kind of beliefs, environment, etc., and take in consideration what is the patient understanding from the disease. Next slide, please. So when researchers try to look for what are the patient's preference to receive bad news, this is very aligned with what we have seen before. So CAYA cancer patients prefer tailored communication, so communication that is considering their age, cognitive development, discussing the physical and social effects unique to the CAYA generation, a communication that explains the long-term risks involved in treatment choices, empathy, but avoiding excessive empathy, which means that CAYA cancer patients do not want superficial empathy. They don't want to be forced to explore emotions. maybe they prefer someone to tell them, okay, this may happen, and if this happen, you can make something about this, but not to speak in the moment, to be forced to speak in the moment. They also want a communication that support their decision making. And I know Anna already spoke a lot about hope, and there is something else in the communication that CAYA patients prefer, that is so they want honesty and transparency, but they also emphasize the importance of portraying information in a positive, helpful manner. Because we listen very often, healthcare professionals saying, okay, we don't want to give false hopes, but giving false hope is not the same, not giving false hope is not the same of removing all hope. So if we think about just the treatment perspective, okay, maybe the healthcare professional cannot provide any information about more treatments or anything to cure, but if the healthcare professional perceive the patient as a person and not as the disease, they may offer some ways to cope, something that is important for the patient quality of life. So basically is this, and this is also related to the tailored communication. The patient does not want to be seen as the disease. Next slide, please. So, okay, to make it easy for this presentation, I decided to create these categories about the things that we do not want to listen, and I'm including myself, of course, because I'm also a cancer survivor. And these categories were created based on evidence that I collect, but also my personal experience, listen to others. So basically, what we do not want to listen is something that make more damage. So cancer, it's hard enough. So please do not say anything that cause more damage, more harm. So please do not say anything that blame, impose, label, compare. Do not create this toxic positivity, or as Anna said, Dr. I don't remember exactly the word, but it's the same thing, Dr. Sorry, I don't say now. Tyranny, positivity, or dispersonalize or minimize, judge or criticize. So I will give you some examples in the next slides. I will not read all the examples I wrote because we don't have time, and some of the ideas were already shared by other speakers. So when I said to not blame, is to avoid this kind of expressions that link the cancer to any kind of behavior that the patient has, because first of all, it's not correct to say that the cancer happened because something the cancer patient did, especially when we are speaking about young cancer adults or teenagers or children. And then because that is not helpful for the cancer patient. So, for example, this cancer happened because you were always stressed. This is also very harmful because, yes, we may feel stressed when we have a diagnosis like this, and Anna spoke a lot about stress and fear already, or say something like, stop worrying, you will not recover that way. So it's also saying to the patient type of behavior that will not help. And this kind of statements that also include religious beliefs or spiritual beliefs are also very harmful. They also create this sense of punishment. And I said about behaviors, and also sometimes sexual orientation. I remember a patient saying that, okay, it was super hard to tell my family that I was homosexual, And then the cancer happened, and it was like I was being punished for my sin. So be careful about this kind of comments. It's not just blame, it's also judging, criticizing. Next slide, please. Do not impose, is imposing behaviors, imposing feelings, imposing ways of experience, having this experience of cancer. So you should be grateful, at least you are alive. You should be grateful, like we listened. Anna said that she also feels this by herself. It's not imposed by other people, but we listen this very often. And we know that a lot of patients say they feel grateful, but are they feeling grateful immediately after the diagnosis, or it's a lot has happened since then? So take care about saying these things immediately to the patient. Don't cut the steps. So let the patient decide if he feels grateful or not. So telling what the patient should do and when. We know that cancer does not end when the treatment ends, but a lot of people believe then they ask to the patient to have a certain kind of behaviors as soon as the treatments are done. And this kind of advices about recipes for cure that everybody suddenly knows about medicine. This is a lot, another complaint that patients have. And even you will be okay, you are going to beat this, let's speak about something else. It sounds like it's a message to give some support, you will be okay, but then the patient can say something like, how do you know that I will be okay? You don't know. And let's speak about something else, is putting the idea that, okay, I don't want to speak about it. So do not impose. Next slide, please. This is an example from a cancer patient, but she's not CAYA cancer, but even so, it's so powerful that I decided to bring because I guess it's very relatable. So Barbara, and I'm sorry I cannot say her last name, she was very tired of all comments around her about being positive, and she decided to openly write about the way she was feeling, sad, mad, etc. And she got this message from one of her friends. I really dislike saying you have a bad attitude towards all of this, but you do, and it's not going to help you in the least. So it's very aligned to what I was saying before. She was imposing a certain type of attitude and saying, look, if you don't behave this way, you will be sick, you will not cure cancer. So next slide, please. Again, one of our ambassadors also shared this, and you can listen to her podcast. Sonia told, when I was diagnosed with this challenging illness, I quickly realized that society has these unrealistic expectations for cancer patients. They want us to put this constant facade of positivity. So a lot around positivity, and I saw quickly someone in the chat saying something about, in general, feeling positive, and it's okay. It's not about, there is no right or wrong attitude, and it's okay if you feel positive. The thing here is when people impose you to be positive, when people say that you need to be this way. Next slide, please. So other things that that is very common is to listen from some IS patient complaining about labels: fighter, warrior, hero, brave, cancer victim, or inspiration, or other labels that have this idea of a stoic attitude. So one study from Macmillan Cancer Support showed that 42% of the participants consider this empowering word. These participants were not all CAYA cancer patients, some were, others were not. Still, what we can see is that 42%, so there is a percentage, 58% that probably agree. So the message here is there is no one size fits all. It's okay if some people like this kind of labels or relate and others don't. For example, Craig Tolley, who is a cancer patient, spoke about this, and he said, personally, I found those words helped empower me a lot and made me think of my cancer as a challenge I needed to fight. So there is no one size fits all. We have a responsibility if someone tells us this kind of words and we don't relate with them, we should say as well, okay, don't use that terminology for me. I know that probably you listen some patients who relate, but not my case. We can also see a lot of patient influencers that use this kind of terminology. Next slide, please. And do not compare. So I, as cancer patient, don't want to listen someone else saying about another cancer patient that died. So again, it's about thinking, why am I saying this to this cancer patient? What this message that I'm sharing will add is harming him or her, or this will add anything that is good for the cancer patient? And possibly no, because if we think about IS, probably they all know that cancer is a life-threatening condition, so we know that we can die with cancer. And comparing, saying things like you are a young adult, there are also children suffering with cancer. That does not remove the pain of you having your own cancer. And this is a very hard comment to listen. There is another thing that I, a cancer patient, know, that there are children suffering with cancer as well. And maybe the cancer patient can say to you, okay, there are children facing cancer, but there are older people than me facing. So these are the kind of comments that can create more angry and may lead to isolation, etc. And some patients also say that, okay, I'm tired of listening that in the future I will appreciate my life, blah, blah, blah. So take care about these kind of comparisons. Next slide, please. Almost all statements I was giving had more than one label of category that we don't like. So in this slide I put do not dispersonalize, do not minimize, or do not judge, because this dispersonalize is like when you are removing the person identity. So when you say things like, yes, you put on weight, but you are a cancer patient, you should not worry about it. This is hard because it's not, okay, you have cancer, now you need to forget about yourself. And, you know, if we are IS, we are in a phase that we are developing, we are really relying on our self-esteem, in our development, in our characteristics, in our body. So obviously image is important for everybody, but it's even more important in this phase of development. So you have a cancer that is hard and you are putting weight and it's hard. So don't say these kind of things. Don't say you should not be thinking about your hair. And this was very specific to me because it was one of the first communications I had with a male young cancer patient. He was complaining that he wanted to use a wig and nobody was supporting him because some men shave their heads and he was a male, so why to think about a wig? But for him, image was important as well, of course, and shaving our heads because we decide to shave our heads is not the same as having a cancer and be bald. don't say at least you do not have the most aggressive type of cancer. It doesn't matter. It's cancer. It's the way we are receiving the message. It's cancer. And at least is not empathetic. It's something that we all do sometimes because we are all humans. But when we say at least, we are minimizing, we are taking, we are not connecting with the person, but doing the opposite move. So these kind of things, or you are still young, you have a life ahead to live. We don't know when we are facing a cancer, if we have a life or not to live, but we can say things like, okay, yeah, I'm very lucky. I'm young and I have cancer. You are old and you didn't have a cancer. So again, this can increase anger and make the cancer patient feel more more isolated, not looking for this kind of support because it's not support. Next slide, please. So I have some personal examples. They are all in the healthcare setting. It's not because I didn't have bad examples out of the healthcare setting. I also have, but these are two situations that I can relate as having put a toll on my mental health. I really had consequences of these conversations. The third situation I will describe is a good one, but these were too bad. So the first situation, the surgeon said, and I will say this before read the context. So the surgeon said, what did you study? In what university? Do you heard about lympha? You may develop lymphedema. You cannot run, etc., but this is not reversible. Your legs will be swollen and swollen. Okay, so do whatever you want, but not complain then. Do you want antidepressants? So I will now give you the information to fill the gaps. So this conversation happened on the 26th of December, 4 days after my surgery, my first surgery, 2 days after I received my diagnosis. So yes, it was a diagnosis that I received on the Christmas Eve. This was the first time I saw the surgeon after the surgery. And I was not feeling my legs since the surgery. They were numb, they were weird. But when I received the diagnosis, I was in trance, so I could not think about my legs. I was just trying to understand what was the diagnosis. So when I finally had a voice to say to this surgeon that my legs were numb, I received this. And lymphedema was not something we discussed before the surgery, I mean. And before I get sick, I used to run every day. So in the gaps, what did you study? I replied to him psychology, and he asked me the university. And then he told me about lymphedema, and it was a second-arm diagnosis in 2 days. He was saying that it was something that could happen and is not reversible, and maybe I could not run, or if I wish, because I told him, but I used to run. I was incredulous. I was in shock, and he said, okay, so run, but then do not complain if you get worse. And finally, he completed with the antidepressant. So this was an experience for me that was hard, because after I ended up developing lymphedema. And before I developed lymphedema, I was terrified. I was having a lot of behaviors to avoid lymphedema. I was super nervous for a period in my life. I was waking up every morning thinking, will I develop lymphedema? And in the end, I feel like it was not warm. It was not listening to me or see me as a person. It was standing up. I was lying. It was not sitting next to me. So all of this, and is the way he was receiving my emotions, he was not prepared. So that's why he was offering me antidepressants. Also, these questions about the university, I think they were a bit stereotyped, but not a good way to perceive my understanding. And then a second situation with the gynecologist. So this was a few weeks after my surgery. He asked me, are you having sexual relationships? Why not? You are still a normal woman. So this was very weird. I was in this appointment a few years after my surgery. I was still wearing a brace. I had just received a small cell ovarian cancer diagnosis. I had no boyfriend. I was in an appointment with him and several interns. They were my age, female and male, and he was asking me this during the examination. So we know that there are some guidelines saying to doctors speak about sexuality, and they should. We know they should. We want that they speak with us, but not in these conditions, not in this situation. This is a sensitive topic. I had no privacy, and he jumped in conclusions. He asked me, but immediately said, why not? You are still a normal woman. So when I was leaving the room, I immediately asked my mother, should I not be feeling like a normal woman? And this was hard for me because this was exactly the moment I started asking myself, am I a woman because I have ovaries? Am I a woman because I born a woman? This started to make something in my self-confidence, in my self-image. So it was a trigger. Next slide, please.
Thank you. Thank you so much, Oriana. So I think it's this is a really good thing that you shared, and we are so very thankful for all the insight. And I think there's a lot of comments and a lot of conversations going on about it. Do you mind if we forward very quickly to where you're giving some examples of what to do actually? I think it's like a really nice slide to stop on. I know Asta will find it very quickly. The next one.
Yeah.
So the next one, if you don't mind.
Yes, of course. So my suggestion is some tips and advices to improve communication. So when we start speaking about this topic, we may ask ourselves first, we can ask ourselves, how am I feeling today? Am I capable to support? Because we know that we need to take our self-care first before we can be good to someone else. So to support someone else, we need to make our self-care a priority. And we should ask ourselves, what is my role in this person's life? So if I am a friend of this person, what is this person expecting from me? Okay, maybe she's expecting someone that listen to me. What do I know about a cancer diagnosis? What did I listen from this person saying to me about the diagnosis? So I considering her or his diagnosis based on his experience or in my previous beliefs. What kind of questions can I ask? Do I need to ask this? What I do expect to obtain with these questions? So to not blame, to not compare, etc. Do I need to really ask those questions? They are giving me something that is important, or just putting harm and damage to the patient? And what are losses or the impacts that this disease is causing to the patient? And what is the phase the patient is living in his cancer journey? So if we have this kind of self-questioning before, maybe we will stop a bit and be more aware about what we are asking to the patient. It doesn't mean like we will not say something. Of course, we are all human beings. We are not robots. So if we say something that we regret, we then can apologize. And this is not me about saying, okay, let's start with the statement in this way, because again, we are not robots. It's just to have some awareness. So next slide, please.
So if you don't mind, Oriana, so this is a really, really nice slide with key takeaways, as you said, and it summarizes the things that you shared. But because we have really come to the end of the webinar for today, we would like to say a massive thank you for all the things that you shared. And there were so many comments. I've seen a comment from Carmen saying that this was so thorough, that even though, you know, we are patients ourselves, some of the listeners of this webinar, we still have so much to learn, because even when we support one another, we should be remembering some of these points that you have shared, Oriana. So that's great. And maybe just to remind everyone that there's a Discord community. You can find it on beatcancer.eu. Go to tab community and you will have access to the Discord page. And there was another one also from Giovanna and some other things that people are saying that are unhelpful. And this is a wonderful slide to remember. So massive thank you, Oriana. Amazing, amazing talk and incredible stories that you shared from your personal life and a really good summary. The next webinars. Ulrike, I believe you are responsible together with Karina for organizing the next one too. It will be on education and career support on the 24th of October. There will be a German language webinar coming up. Yay! On the 20th of October. And you will find about it more on beatcancer.eu. Before we say goodbye to everyone, and thank you, because more than half the people stayed on. So amazing, thank you. Maybe just if there is anything else that our panelists would like to share before we go. Alit, Karina, Ulrike, Oriana.
I think just from my side, if out there you are not connected to any peer community, but you would like to then do reach out. So I think what we experience here, you know, in our network is that, yeah, having the opportunity to speak with people who have experienced similar things can really, really help.
Amazing. Thank you so much. And I see that there's a link now for everyone who is following us. And maybe we will also put it on Facebook as a comment under the stream that will be available for later on. So a big hand to Oriana. Thank you so much for that very thorough explanation on what not to say, what to say to cancer survivors and cancer patients. Big thank you to Ulrike for the overview, the A to Z of mental health when you're diagnosed with cancer. Big thank you to Alit for explaining to us the difference between grief and depression and a very clear list of when to ask for help. Please don't be shy. Massive thanks to Asta from Pola for helping us with all the logistics and all the slides and everything that were shared here today. And all the other panelists, William, who had to leave, and Hannah as well. Did I miss anyone? No? Then see you at the next webinar. See you on Discord. See you on the project website. And have an amazing, wonderful evening, everyone. You've been wonderful. Thank you so much. Let's keep supporting each other.
Thank you.
Bye.
Thank you, Katie.
Bye.